Afternoon, good morning, and good evening, everyone. Thank you for joining us today on our monthly webinar session. So this is Tersit. My name is Tersit Mahari. I'm a global primary health care program lead at the International Institute for Primary Health Care. So this International Institute for Primary Health Care in Ethiopia is established by the Ministry of Health in 2016. So it has been 80 years since we have established and working to be a center of excellence in primary health care. So we are providing different capacity building programs, researches, and advocacy work. So this webinar series on primary health care is one of our efforts under the Global Primary Health Care Program. So we have been doing this for the last 3 years, and it turned out to be a good experience to share countries' experience on primary health care, to learn from each other. So this is it's also an exciting platform to engage with you and with everyone. So today we have an interesting session on quality of service in primary health care. So quality is a significant and an important point in health sector or health system delivery. So that we would like to advocate for and work towards that in any way that we are working as an PHC or International Institute for Primary Health Care. And today we are collaborating with PAS, one of our partners in our efforts and our work. So we'll be starting our session. It will be a 90-minute session. We have an excellent speakers today here with us, for speakers from Ethiopia, from Kenya, WHO, AFRO, and India. So I hope you will be learning a lot from their experiences. And to start with our session, I will be also introducing our moderator today. I'm really honored to introduce Dr. Kimberly Green. She is a global director at PAS on primary health care program, which includes teams focusing on health system and health areas across the life cycle. Dr. Green has more than 30 years of experience in public health management, policy development, and research. She deeply believes in power of primary health care to improve health access and equity, and is specifically interested in health service delivery innovations, the role of community and lay provides in delivering healthcare, self-care, and digital health, private sector partnership, and social and behavioral change communication. Dr. Green is clinical associate professor in the University of Washington Department of Global Health and deputy editor for Journal of the International AIDS Society. She also serves as a member of WHO and others scientific guidelines and advisory committees. She holds a master's degree in international health and development from the George Washington University and PhD from the London School of Hygiene and Tropical Medicine. So please allow me to welcome Dr. Kimberly to moderate this session. I hope you all have a good time with us. Thank you. Over to you, Dr. Kimberly.
Thank you so much, Dr. Mahari. Thank you for the very lovely welcome. We are so delighted to have all of you here today for a very dynamic discussion on different aspects of quality and what it takes to strengthen quality in primary healthcare. So before we get started with our content, I would like to go over some logistics and housekeeping items. So in the spirit of person-centeredness and community-driven primary healthcare, today is meant to be a very participatory webinar, and so we would love for you to engage in a couple of different ways. One, putting your comments and reflections in the chat, and our panelists can respond to them throughout the webinar. But also towards the end of the webinar, we will have a moderated Q&A discussion. So please do use the Q&A function at the bottom of your screen to share any questions that you might have for anyone or all of the panelists. So I see many of you are introducing yourself in the chat. Thank you. It's lovely to see people from all over the world joining us and from many different specialties. So to get us started, when we think about high quality primary healthcare, it's really the outcome of well-organized and managed services that are backed by a robust system and adequate inputs such as human resources, infrastructure, essential drugs and supplies, and an empaneled workforce. So it's really the foundation of trust in and the value of services provided by the health system and in improving health outcomes for all. So that is quite a bit that is really the parameters of thinking about quality in primary healthcare. And yet we face a number of challenges in quality and as a result, challenges with uptake and utilization of primary healthcare. So today we have 4 stellar leaders in primary healthcare who are going to be talking about different solutions to address some of the challenges that are commonly faced related to quality. We will have Dr. Al-Hassan Kanu, who is with the WHO AFRO office, Dr. Binyam Deste with JSI in Ethiopia, Dr. Radha Karnad, who is from HealthX Africa and Kenya, and Dr. Mayank Sharma, who works with PATH in India. So I'd like to introduce our first speaker, Dr. Al-Hassan Kanu. He's a public health and health systems scholar and practitioner and has expertise in health system strengthening, reproductive, maternal, newborn, child, and adolescent health, and health security and emergencies. Prior to WHO, he worked with the National Ministry of Health and with international NGOs in Sierra Leone, as well as with the World Bank and UNICEF. Dr. Kanu, we are so grateful to have you with us today. I'd like to turn over to you to frame your presentation on primary healthcare in Africa and progress towards quality of care, including in Sierra Leone. Over to you. And Dr. Kanu, are you able to go off mute?
Sorry, Dr. Kim. Can you please share on your end, please?
Yes. So yes, we would be grateful if the IPHCE team can please load up the slides.
Thank you very much. Thank you.
Yes. I think there's a difficulty. So Dr. Kanu, as we wait for your slide.
Yeah, I'm going to share the screen. So Dr. Al-Hassan, you can maybe start.
Thank you very much.
Thank you. And Dr. Kanu, while we wait for the slides to load, feel free to provide further background on what you'll be presenting and also on you.
All right. Thank you very much, Dr. Kim, for the presentation. Sorry for the introduction. My thanks also to the IPHCE for the opportunity to have Sierra Leone as a country to share our experience on our journey to providing quality healthcare services to the people of Sierra Leone. I'm a public health system practitioner currently working with WHO, as you actually mentioned. But previously, I worked with the Ministry of Health and Sanitation in my country for over 15 years before moving to become a public health consultant internationally. So next slide, please. Right, this is just a disclaimer. I was formerly a staff of the Ministry of Health, as earlier mentioned, and currently working for WHO in the AFRO region. I want to say that I'm not here to represent any of these institutions. And whatever I say here has to do with my experience working in the two organizations and many other organizations across the world. Over. All right, that's just my outline. I will be looking at an overview of my healthcare generally, and that will be followed by our experience as Sierra Leone and our lessons learned. And based on my experience of supporting countries in the African region on health system strengthening initiative, I will share our shared challenges and best practices around my healthcare, then the way forward. Next slide. All right, these are just definitions on primary healthcare and quality of care, which I will leave you to read. But I want to emphasize that primary healthcare acknowledges health as a fundamental human right influenced by biological factors, social and environmental determinants, health services, and public policies. It is considered as an important foundation for the achievement of equitable improvement in health outcomes globally and at a country level. And from those definitions, it captures well all the considerations around focusing on the individual, the family, and general community. And again, we talk about safety, timeliness, effectiveness, and efficiency with regards to quality of care. Next slide. These slides are referred to as the mechanics of primary healthcare, basically trying to illustrate how primary healthcare works as an approach. This framework shows how we should be able to understand the outcomes that need changing, and then closely examine the key root causes of the outcome. And if you look at the framework, it exhibits an overall directionality of influence, where the health system domain, that is the wider national system of government, and the Ministry of Health can influence the input domain, which affect the complex interplay within the service delivery domain. Thereafter, service delivery contributes to effective output, which subsequently affects outcomes. So in essence, achieving the overall goal of primary healthcare depends on several factors, and hence the need for integration, synergy, collaboration, complementarity, and even working with our communities that we serve. Next slide. Now, our experience as a country in Sierra Leone. If you don't know Sierra Leone, it is on the west coast of Africa. We have one of the 5 English-speaking countries in the west coast of Africa, with about 8.5 million people, and administratively, we have 5 regions and 16 districts, and over 150 chiefdoms. These are just our key health statistics. As you can see, we have over 1,200 primary healthcare units. And again, like any other country in the region, we are challenged with the right numbers of the human resource required as per WHO recommendation. Next slide. Here, we are doing so well on our outcome indicators. As you can see, over 80% of deliveries are taking place in health institutions, and these are predominantly primary healthcare facilities. Next slide. All right, on our impact level indicators, Sierra Leone was renowned of having one of the highest maternal mortality rates during the immediate period of our 10-year civil war, with over 1,000 deaths per 100,000 live births. Currently, maternal mortality rate is 443 per 100,000 live births, and we've seen similar reductions for under 5 and other indicators. The sustained commitment by our political leadership and the support of our partners, the FCD World Bank, towards improving the health aspect of Sierra Leoneans actually contributed to the changes in our impact level indicators. Next slide. All right, this schema just shows our service delivery levels in Sierra Leone. The faded blue there refers to our primary health care, whereas some secondary, tertiary are right at the top. So primary healthcare services are provided at 4 levels. That is at 3 types of facilities, which we collectively refer to as a peripheral health unit, and at community level. The PHUs are classified with clearly defined functions, as you can see. The first level PHU is the maternal and child health post, which is the closest to the community, and then the community health post, and at the top, we have the community health center. Also, we provide a range of preventive and basic curative services through the CHW at a community level, community health workers at the community level. And these CHWs are linked to primary health care through supervision, reporting, and supply chain management. Next slide. All right, this slide just shows our progress in advancing primary health care. Strategic efforts was made after the Civil War towards rebuilding our health sector and other social services. The country adopted and operationalized a range of global health agendas, including the introduction of the free healthcare services. The free healthcare initiative was meant to increase access to vital or important RMNCH for our women and children, and also we revitalized the CHW program in a way to increase access to critical services through the CHW health workers. Next slide. And then again, on the progress on quality of care, as a country, we acknowledge that quality healthcare is one of the major contributing factors to the poor health outcomes. So since 2018, concrete steps have been taken to improve quality of care. And in 2019, we had the first ever national quality management program. Today, we have quality improvement structures at all levels, including the communities. Next slide. Next slide, please. Right. So, in addition to the governance structures and systems to improve the quality of my healthcare, there have been several innovations and initiatives which were instituted, and key among them are presented here. We have mentorship at facility level, integrated supervision. There was performance-based financing introduced just to incentivize health workers to do more and invest in also the health facilities, and even engaging community through what we call facility management committees. And all these have contributed a lot in our achievements as a country. Next slide. So these are just some of the achievements we can say we kind of made over the years. Of course, with quality emphasis, we have seen an increased government commitment to the health sector. And again, also engaging communities. We have very key important structures, the BDC, the FMCs, the mother support groups, all have translated into increased service coverage, among others. With regards to lessons learned, we realized that by establishing a quality of care program actually enhanced guidance and stewardship for improving quality at all service delivery points. And again, with that committed leadership, our partners were wooed and invested so much in improving quality of care at all service delivery points. And also, hands-on support is really making a difference here, where advisors and trained people work into facilities and support the health workers. And we have also seen leveraging on opportunities around global webinars, which have empowered both advisors and the leadership of the ministry towards improving quality of care. Next slide. Now, we look at what is happening around Africa generally with regards to quality of primary healthcare services. From a supply side perspective, our systems are fraught with huge challenges in providing a responsive and quality PHC services across Africa and in many other low-income countries. So using a health system lens, the following are shared bottlenecks in the primary healthcare system across Africa, across the WHO health system building blocks. Under leadership and governance, there is absence of effective and well-resourced regulatory bodies. This will need to really guarantee care. And also, there is no strong and functional quality management structures. For Sierra Leone, we are saying, yes, we are having that now. But in many countries, these are still not fully operational. And also, as countries, we have a lot of guidelines, a lot of protocols, but operationalizing them has really been the key. And partner coordination is also a challenge. On health financing, our health systems are underfunded. We rely largely on donor support, and that is really not sustainable, and it affects quality of services. On health workforce, yes, there is lack of regulatory bodies for health professionals, and also we don't have the appropriate numbers, the appropriate skill to be able to deliver responsive healthcare system. For medicines and technology, there is a stock out of essential medical commodities, and that also affects service delivery. On service delivery, we are fraught with needless delays, needless harm, waste of resources, and our decisions clinically are not evidence-based. And in Sierra Leone, for example, we have issues where health workers have been accused of verbally abusing service providers. And by doing so, you are going to turn them away from going to the facilities and they will go elsewhere. Health information system and research, here again, there is not adequate research work done to inform what we do in our practice as primary healthcare workers. So these are shared challenges we have across Africa and beyond. Next slide. Right, so with all the challenges, we have seen what we can refer to as a best practice, i.e. improve governance and finance of my healthcare. Yes, our governments are still challenged to give the right resources, but they are making incremental contributions on a yearly basis just to ensure that we achieve the my healthcare goal. And again, integration is really well appreciated. And following COVID-19, there is a concern now towards promoting health worker safety. And today we are seeing IPC structures being put in place just to ensure health workers are safe, equally so for their patients. Of course, task shifting, where we introduce stage of rules, where we train other cadres across various clinical skills just to ensure we fill the gap. Community engagement is going up, and also a culture of mutual learning among stakeholders. We, as a Minister of Health, you can provide everything. Health goes beyond just medicine, but rather, how do you address other factors that really contribute to poor health? So collaborate with the Minister of Education, Minister of Agriculture, for example, all has contributed a whole lot in shaping our primary healthcare service delivery. Of course, the partnership with the private sector is also helping out a lot. Next slide. All right, on the way forward, there has been a renewed consensus on the potential of primary healthcare to facilitate the achievement of PHC and other health-related SDGs. And regarding the implementation of key transformations and reforms of primary healthcare, WHO and UNICEF developed this operational plan, which you can see, I call it the theory of change. And of course, with the PHC approach, there was service delivery in an integrated fashion, It's about empowering communities and people, and also multi-sectoral policy and action. But in between, you have the PHC levers or enablers at strategic level, and also at operational level. So about 13 of them, as you can see there, we need commitment politically, we need strong governance arrangement, of course, funding and community engagement at the strategic level. And going down to the operational level, we need our workforce, we need the right infrastructure to promote quality, and a whole lot. By having those levers fully operational, then the result will be improved access and installation of quality care, and also improve participation, health literacy, and care seeking, and above all, improve health determinants. And by extension, all this will contribute to our attainment from the SDGs, especially goal 3, and of course, universal health coverage. Next slide. So, areas of focus for us to have a resilient and a responsive primary healthcare oriented health system in Africa should therefore include the following. We need to prioritize health funding. We need to invest in healthcare workers, and also including CWs. We need to have a very responsive service delivery. We need to address constraints around supplies so as not to disrupt service delivery. And we need to continue to engage communities and build public trust. That's the only way communities will come and make use of our facilities. And most importantly, strengthen multicultural approaches and partnership. Next slide. Before I leave you, I want to refer you to a commentary made by the Director General of WHO titled, "How Could Healthcare Be Anything Other Than High Quality?" just published on the Lancet, right? And here he said, without quality, universal health coverage remains an empty promise. Even with increased access to services, health improvements can remain elusive unless those services are of sufficient quality to be effective. I appreciate you very much. In our Sierra Leone local plans, I say thank you. And we say Amazidonalo, and thank you, merci in French, and shukran in Arabic. Thank you very much, and over.
Thank you, Dr. Kanu, for that excellent presentation. Really brilliant framing primary healthcare, the rationale for it, but then also focusing specifically on some very important and impactful learnings related to quality, specifically in Sierra Leone. I think it's so interesting to hear about the mentoring approach, about the integrative supportive supervision, and really importantly around engaging the community through community scorecards and community involvement in the management boards for primary healthcare, and so much more. If you have publications on these approaches, I know that our participants would love to understand more of the details on the how these different initiatives were applied. So please do feel free to post those in the chat. We also had some excellent questions related to the role of live research, integrating research into primary healthcare to understand quality. So thinking of around continuous quality improvement strategies and adaptive learning. So Dr. Kanu, I'd be grateful if you could respond to that question in the chat. And then as well, it's an excellent question for us to address as we get to the Q&A. It's also a great question. Thank you. On the community health workers during times of crises and how they were effectively supported. So keep those questions coming. They are excellent. And our panelists, please do respond to the questions, and then we will get to them during the Q&A. So with that, I would like to turn to our next speaker, Dr. Binyam Desta, who is from JSI Ethiopia, where he serves as the Chief of Party of the USAID Quality Healthcare Project. Prior to this role, Dr. Desta worked as Deputy Chief of Party for the USAID Transform Primary Healthcare Project. And in this role, he led efforts to prevent child and maternal deaths. He also directed projects with the Gates Foundation and has worked with the Ministry of Health in Ethiopia, as well as regional health bureaus, to institutionalize primary healthcare reforms. So while at the Ministry of Health, he made contributions to the development and revisions of multiple policies, strategies, and guidelines. So with your practical experience in policy change, reforms, and implementation, over to you, Dr. Desta, to share more about quality of care strategies in Ethiopia. Thank you.
Thank you, Dr. Kim, for the introduction. Yeah, so our present experience from Ethiopia, and talking about primary health care. So the first thing is Ethiopia has more than 22,000 health institutions that are providing primary health care to 120 million people. And with regard to the health workforce, especially the essential categories with regards to the service provision, we have 1.2 per 1,000 population, which is half of the standard set by the WHO. And quality of care, yes, the quality of care has some issues, and taking the 2018 SPA data, quality index was developed, and that index includes evidence-based care, competent system, and also user experience. So that assessment resulted to only 13 out of 100, which is by far lower than expected in terms of the quality index. Primary health care and quality has been a key priority of the government of Ethiopia since the introduction of the health policy in the late 90s up to the recent investment plan. So in the first health sector development plan, it was primarily focused on the community health program. At that time, Ethiopia introduced the health extension program with salaried health extension workers serving community, especially on prevention and promotion. Initially, later, they have included basic curative cares. And later, we've introduced business process and engineering to reorganize our service delivery model, as well as the tier system. And later years, regulatory bodies were established, and that regulatory body provided support to Food, Drug, and Health Service Administration. And then later, now we have Food and Drug Administration Authority, which has been providing paperless services to their clients, which been supported by different partners among the influencers. So the other one is the health sector transformation plan. And the transformation plan, Ethiopia set different agenda, and one of them is the quality and equity, and also district transformation. Those are very relevant in terms of primary health care management and the quality of care. And the recent health sector development and investment plan has also introduced focus in harnessing innovations to further improve the health system's quality, equity, and safety. So as you see, all of the primary healthcare related issues and quality has already been included in our policies and plan. So while implementing those plans, we also had two rounds of strategies. The first one is on the national quality strategy, which was between 2016 and 20. We were focusing on establishing a structure and having a concept of improvement linked with universal coverage and also a feedback system. So like when we finished that implementation of strategy, there was a terminal evaluation conducted. Pretty much more than half of the facilities have established a strong quality structures, and also introduction of quality structures at the state level and at the national level were strong points. And the improvement areas identified at that time is coordination among different units, and also weak community engagement to quality improvement. So taking the lessons from those evaluations, another national quality and safety strategy developed that focused on more of safety, evidence-based care, and also efficiency in the healthcare system. So midterm evaluation was also just conducted this year. It's not yet finalized, but it shows that majority of the key performance indicators are in good progress, and the integration of quality and safety are now being taking shape, but still compulsory Ethiopia health facility standards is not implemented in many of the sites, which requires again focus. So when we think of again quality primary health care, as mentioned by Dr. Al-Hassan, the WHO guidance is key. So systems for improving quality of care is one of the levers, and when we say systems, it includes the local levels of national and national level, and it requires the government to continuously assess and improve the quality of integrated health service delivery. So one of the assessments is identifying the challenges, as rightly presented by Dr. Al-Hassan. Again, many of the challenges are similar to what he has presented. We have many of challenges with our leadership and governance, health information system. We don't have sufficient quality measurement indicators included in our rating system. Content of care is also suboptimal, and service inputs and activities are all common challenges across Africa, and Ethiopia is no different for that. So taking all these interventions, the government with the partners have introduced a number of interventions. And the first one is introducing an evidence-based practice. Taking a lessons from South Africa, Ethiopia has introduced the primary health care guideline. This guideline is an important element for service provision at the primary care level. So it has been a chart booklet where a provider can speak to the guidances and the recommendations in that guideline. Post-op treatment guideline is also another guideline which has been rolled out to health facilities and hospitals. And different disease and program-specific guidelines have also been updated regularly based on the WHO guidance and lessons from the field. Regulation and accreditation is also another area that the government has been doing. The compulsory regulatory standards, we had 2 rounds of revised standards, so a rollout has been there. So based on the midterm evaluation, about 60% of its facilities are following these compulsory standards. It requires more support. And other one is accreditation. There has been some laboratory accreditation or specific service accreditation services in Ethiopia. Now the government is trying to introduce health facility accreditation program. The roadmap has just been endorsed last month, so the rollout is the next activity. Administrative standards, we have a number of standards based on the facility types. This has been an important tool, especially when we have new graduates or less experienced health managers assigned to lead health facilities. So these are an important tool for them to guide the implementation as well as measure their progress, and also has been a very important tool to compare performance among different facilities. Practice and innovation, clinical audit, and system bottleneck focus reform, which is a recent introduction in the system, which has been implemented in selected hospitals, which has really helped them to improve the overall performance with regards to quality as well as efficiency and resource use. So innovation management guideline is also another guideline which has been recently finalized, so that includes identification of innovations and also the strategies to scale up those innovations to the wider scale. So the other category is the type of investment which are very relevant at the lower level. One is the information system. DHIS2 is our platform to gather information, and now significant number of health facilities are reporting, but recently due to conflict, there has been some disruption in some areas, but pretty much many of the health facilities are using DHIS2 as their reporting platform. Quality measurement, there has been some discussions to introduce quality measurement, and one of the thinking is to introduce quality index. The other one is introducing effective coverage as a measurement of quality, and also care cascade is also the other type of measurement that governmental partners are thinking to introduce. So indicators to measure performance has been there. So we have a high-performing primary health care measurement platform that we've been using. Leadership is very critical in leading primary health care quality. So high impact leadership development program is now being introduced by the ministry. The documents are just to be finalized. So this is a 6-month program, which includes some mentorship and also trainings for leaders and also women or leadership cohorts, so that the government encourages women leaders to assume some roles. And the leadership incubation program, which has been implemented for the last 3 to 4 years under the Ministry of Health and the Institute, so that we have a good number of leaders assigned in different facilities and administration structures. Community engagement, we have like community scorecard is being implemented in about 75% of village that we have for Kavales, citizen charter, town hall meeting, and patient and client engagement platforms, all are being implemented in the country so that the community has some voices in influencing quality. So collaboration for quality is also another area which has been a key part of our investment, of hospital to hospital, health center to health centers, and also strengthening the primary health care functionality as a unit is also another collaborative platform that the government has been implementing. This platform has been critical in pushing the learning and the sharing among health facilities and health system administration. So that is the third component of quality. So this has been an important and comprehensive primary health care and quality investment in Ethiopia. So to give you one example, a recent investment funded by USAID, which is the USAID Quality Health Care Activity, is a 5-year project implemented in more than 81 districts, both in public and private facilities. So this project has a number of result areas, and one of the result areas is to improve quality and accountability. So we think we will be successful if we manage to introduce this 8th agenda in terms of quality management and accountability. So we are in our 2nd year. So hopefully in the subsequent years we will share lessons from this learning agenda. The one is we are thinking of introducing standard of work revisions to define patient and workflows at the primary level care. And we are also thinking of identifying a model to influence the culture of quality, because quality should be considered as a cultural shift. So that requires a well-guided and evidence-supported model. So we are looking for that. Leadership development as part of the whole system. Quality management is also another area that we've been supporting, and team-based accountability to drive sustainable change, so that the audits and surveillance should make a team accountable rather than individual, so that the support between different cadres of health workers will be strengthened. Blended payment mechanism, which includes performance-based financing and also insurance payment, so that quality will be the core piece of that payment modality. Is also another area that we are working, and including of private health facilities in the collaboratives, in the learning platforms and the support mechanisms. And also we're thinking private facilities to be part of the network of caring practice that we are pushing. Community engagement for better empowerment, and also introducing quality measurement as part of the written health information system. These are our prioritized agenda that we support the government on top of those that I mentioned in my previous slide. So going back to Ethiopia, we think quality is the kind of a progressive realization. So Ethiopia has a clear pathway to achieve that one. So as you see here, there are administrative reforms to be expected to cover every facility in Ethiopia, and also we have a reform-aware platforms, and that facilitates a large scale quality improvement and management lessons. And also we have a minimum compulsory regulatory standard 60% of the facilities are now being using it. And also managing innovation to drive value-based care is also another area that the government has been piloting it in a few sites. And ultimately, the overall goal of this all pieces is to make sure we have a good number of health facilities accredited for the quality standards and the level that they are able to maintain the services that they are providing. So these are my slides, and I'm happy to take more questions later. Thank you very much, Dr. Yusuf.
Thank you so much, Dr. Binyam. It's really phenomenal to see the systematic approach that's been applied in Ethiopia, from defining standards to accreditation to ensuring that in service delivery they're adhered to, but also going beyond that, really focusing on decision making, leadership programs, town halls to engage the community. It's all very exciting, and there's some questions in the chat that I think you would be perfect to answer, including really how the community scorecard is implemented, as well as some of those questions on research and learning to improve quality. I would now like to turn to Dr. Radha Karnad, who is the Chief Medical Officer at HealthX Africa. Dr. Karnad is based in Nairobi, Kenya, and spearheads the development and implementation of strategic initiatives to drive HealthX's vision, a doctor for every Kenyan. Dr. Karnad has lived and worked in Kenya since 2013, her leadership role at Jacaranda Health, Japaigo, and now as lead strategy and growth advisor for HealthX Africa, where she's also the founding team member, have enabled her to put her energy and experience to driving systems change and maintaining strong relationships with stakeholders and opinion shapers in health, including the Kenya Ministry of Health. So over to you, Dr. Radha. Really interested to hear about your work from a private sector perspective and through extending access to primary healthcare through telemedicine. Thank you.
Thank you. Thank you very much. Good morning, good afternoon, good evening. I hope you can all hear me. And I'm really, really delighted and very honored to be able to join you all today to give a perspective really from the ground as a private provider doing something different with digital health, and how we put much of the learning and the thinking that happens at a national level into practice in the work that we do at HealthX Africa. Very quickly, I'll just dwell very lightly on the Kenyan healthcare system, introduce HealthX again very lightly, and really focus on what do we do, what have we done at HealthX to build systems and structures for quality and trust in primary healthcare service delivery through telemedicine. None of this, I think, is going to come as a surprise to any of you, and certainly not since we've already had two excellent presentations that I think present much of the same challenges across Africa as we see in Kenya. The reason we started HealthX, the reason it was founded 3 years ago, was because Kenya has persistently struggled with challenge around low access to quality and affordable healthcare across the country, healthcare, and particularly primary healthcare, preventive and promotive care, all the way through to curative and rehabilitative care. It's been a significant challenge across the country. Just to give you a few examples of the type of a few indicators to build this out, only 50% of us live within 5 kilometers of a primary healthcare facility. That is distinctly skewed towards major metropolises and bigger cities. And of course, further out, it's very, very different and even less access. The numbers around facilities changes a little bit, but we only have 13,500 to serve a population that is now 52 million and continuing to grow. So there just isn't enough, there's not enough infrastructure, there aren't enough healthcare providers to be able to deliver on the vision of universal health coverage and quality primary healthcare that our government has committed to. 1 in 10 families get pushed into poverty every year from healthcare expenditure. So cost is absolutely central to the delivery of quality services. It's very many people choose not to enter the healthcare system at all until very late in their health condition. And so we can't separate cost in any discussion around quality care. And these sorts of statistics are what drove a team of us, mostly clinicians, to start HealthX Africa. Our vision is a doctor for every Kenyan. We truly believe the vision of universal health coverage is feasible, is possible. but it can't happen purely through investments in physical infrastructure and in the hope that we will have enough clinicians by 2030. And so in a country like Kenya, which has extensive digital connectivity, 134% mobile connectivity, not all smartphones, but many, almost all adults have access to a mobile phone. A digital-first primary healthcare solution seemed to make sense, and there hasn't been much looked at in that space as yet. So we were very fortunate to be able to set up HealthX just as the government regulations changed to allow telemedicine as a mechanism for health service delivery. So we are a digital-first primary healthcare service provider. We're a medical clinic, and we provide primary healthcare services that include medical consultation, mental health, and nutrition. Our target population is the millions and millions, almost 80% of Kenyans who are either un- or underinsured. And we do that through a 24-hour availability to our team of doctors who work full-time for HealthX through telemedicine. And we connect to patients across the country to be able to serve them and provide consultations. So that's just a very little bit on us. In the middle here, you see a picture of our digital operations center. It's effectively a very secure and quite fancy clinical call center. And our entire team of doctors, clinical psychologists, nutritionists, and care coordinators work from there. And then there's lots of different ways that patients can connect to us, starting from USSD as the most basic and toll-free to our mobile app and more complex tech. But by far, 80% or more of our callers call through on the toll-free number. You don't need a smartphone. You don't even need airtime. All you need is a SIM card and you can have a consultation. It's quite game-changing for a country where, accessing healthcare has consistently been a challenge. And this is just a few examples of what our virtual clinics look like, which are the more complex ones. We can set these up in community centers. We've got solar-powered ones that you can put into communities where there's no power, where there's no electricity, no internet, etc. So just to give you a sense of what this can look like and what the consultation looks like with one of our doctors. We are not, of course, setting up HealthX in a vacuum. We didn't set it up in a vacuum. I think Dr. Kanu and Dr. Vinyam mentioned guidelines and frameworks in other countries. This is absolutely true of Kenya as well. There's been a real investment in primary care as the foundation, the platform to deliver universal health coverage. And so we have a lot of guidance that we have used in building up services like HealthX across the country. And also more recently, a lot of legislation, including 4 Universal Health Coverage Acts, the Primary Healthcare Act, the Digital Health Act, and the Social Health Insurance Act, all of which speak to the expansion of primary healthcare networks, which is a really new and exciting idea for Kenya. And those are networks that include both private and public providers and specifically speak to the inclusion of digital health. So it's a very exciting time in Kenya because things are coming together to allow for us to really provide quality primary healthcare across the public and private sector that is responsive to what patients want. Again, this is not a discussion exclusive to Africa alone. WHO Europe just recently released this telehealth quality of care, telehealth quality of care tool. And much of what you see here in terms of the domains of patient perspective, access, communication, I hope you'll see me talk about in the work that we're doing at HealthX. So this is a conversation, I think, happening at a global stage, at a regional stage, at a local stage, and also, at really a private sector and implementation stage. And it's really exciting to be part of that. What does quality mean for us? So HealthX was founded with a commitment to quality, and we started our journey really by defining for ourselves what we mean by quality as comprehensive, patient-centered primary healthcare that's accessible, timely, safe, effective, efficient, and culturally appropriate. And so we go back to those different points of accessible, timely, and safe when we're measuring, are we actually achieving the vision we've set for ourselves? As part of this, we started off very early on as making commitments both externally and internally through a patient charter and a quality charter. And these are published, on our website, but also across our facility And they really are something that we hold ourselves to in terms of our values and our promise around quality. And this was very grounding for us as we set up, really a new way of accessing healthcare within Kenya. HealthX systems and structures began, apart from the charter, as I said, with a change in the regulation in Kenya, which finally allowed telemedicine and virtual medical services as a regulated and licensed way of delivering care. So when that licensure came through from the Kenya Medical Board, which was during COVID, it was very important for us as a measure of quality that we align with licensure and with the regulation. So we are licensed as a level 2 facility. We also have a virtual medical services license to deliver medical care. The next and most probably important thing that we were able to do in terms of a lens on quality is the people. Who are the people that came to HealthX? We put all of our staff currently are medical doctors. We anticipate expanding to other primary healthcare cadres, but the reason we started with this was there was a real fear and distrust of telemedicine in the first place within Kenya. People really didn't believe you could have a consultation, receive a prescription without a doctor looking at you, touching at you. And we constantly were getting questions on who are these providers? How do we know who they are? How do we know that they can look after us? So we made a conscious decision to start with medical officers and medical doctors alone, and to expand to other primary healthcare cadres, because that's absolutely critical as our service grows. The first 3 months of our service, we put extensively into training and professional development, because telemedicine and delivering telemedicine, doing a consultation is quite different, obviously, than a face-to-face consultation. The types of questions you ask, the types of documentation you do, with a lens to primary healthcare. The other thing that we did at the consultation phase was really allow our providers the time and encourage our providers the time to not just focus on the acute reason that somebody may be calling, but to take the time to ask about family history, past medical history, medication history, health intentions, health objectives. Are you planning to get pregnant, for example? If not, can we, even though you've called about your cough, can we assist you in thinking through, contraceptive options, etc. So really trying to build in preventive and promotive care elements into every single primary healthcare consultation. And that took a lot of training, including for the providers just to be comfortable with taking that much time. In a lot of other jobs, they've been quite rushed through their consultations. We set standard treatment guidelines as we started up HealthX. These are based on national Kenyan primary healthcare guidelines, but we set, in addition, using international telemedicine guidelines, thresholds for what levels of care we can manage and where we have to refer. And we adhere to those very, very strictly, again, as a key measure of quality, to make sure that we're not holding on to patients that would be better managed and more safely managed in a face-to-face facility. We have workflows for everything, and I'll show you a few examples later, but everything, we work very hard to standardize every single workflow. And simple things, as you see here, everybody is in a white coat with a stethoscope on a virtual consult, which looks something like this. It doesn't really seem to make sense, but it is so important for trust. And we have had patients consistently come back to us and say they feel more reassured in their consultation because the doctor on the other side of the screen is wearing a white coat. So we really tried to think about what are the simple things and what are the more complex things that hopefully lend themselves to really a quality experience in accessing primary healthcare services. Our entire medical system, the entire telecommunication system links to an electronic medical record. You can see an example of it up here. This is all made up data that you can see a couple of names and things. That's not real patient data. And that electronic medical record includes elements of clinical decision support. For example, on medication prescribing, it'll flag up if somebody has an allergy that may be a concern. It'll flag up if there's medications that, that conflict, and also allow us to track outcomes. So we can put in patient healthcare data, vital signs, HbA1cs, whatever that might be over time, and look at the success or the trajectory that patients are taking in achieving those outcomes. So that is a very central part of the work that we do on the clinical side. For quality, I think I mentioned this just very lightly on the toll-free line, but we had multi-channels of connectivity, again, because it was very clear to us from early on that patients preferred, not everyone would use the app. We actually anticipated that the app would be the most popular way that patients choose to connect with us. But from quite early, we started to see different patterns of patients connecting. And we have selected mechanisms that are safe and approved, again, within Kenya for consultations. At the moment, for example, there's a little concern around WhatsApp as a mechanism for medical consultation. So we don't use WhatsApp, although it's very prevalent across the country, as we wait for guidance on platforms for the future that will be approved. Patient feedback is one of the most core pieces of our quality metrics. How a patient has experienced their journey with us, and are they feeling better at the end of it? Did it make a difference to them financially? So we try to get some information from them on not just, again, are you better or not, but your experience, and also are we actually delivering on the promise of quality, affordable primary healthcare through financial savings. A big element of our thinking around quality has been partnerships. There are, hundreds of and thousands of pharmacies across Kenya, and we've tried to be quite selective, for example, on partnerships with pharmacies, labs, and ambulances or rescue services, because we want to make sure that they align with our commitment to quality. So, for example, with pharmacies, we will vet, are they able to track the entire supply chain journey of the medication that they're providing? Are they digitally enabled so they can actually receive prescriptions in an encrypted format that is safe? They're not passing patient data around, in an open manner. How can they guarantee to us that counterfeits, counterfeit medication is a huge problem in Kenya, that counterfeits, they really are putting mechanisms in place to minimize or eliminate counterfeit medication. So we've put certain metrics in place that are quality metrics, even in the way we evaluate and consider partnerships. And in the same way, we have really put a focus both on data safety and security and device safety and security. So we are licensed by and registered with the Office of the Data Protection Commissioner in Kenya, which is a requirement now by law. And they did quite an extensive audit in order to be able to approve us for this, to say that yes, the mechanisms that we have, the fact that we have a call center, but no one is allowed in except clinical providers. The EMR locks out, simple, small mechanisms around data safety and security, as well as more complex tech mechanisms that we've put those in place, is what got us its registration. And similarly with devices, we have very strict criteria on the devices that we use, say, for blood pressure or blood sugar monitoring, etc. Devices we can send to patients or set up in the virtual clinics that we have. They all have to be quality approved and CE marked. Standardization has been at the core of what we do. So here, for example, is a very simple one at the bottom that you see, a workflow that we have around registering patients who reach out to us or pay for us through our website. We have standardized and attempted to standardize as much as we can every single step of our service. So operational guidelines, not just our clinical guidelines, but our operational guidelines and policies. We have scripts for every piece of a clinical journey except the actual history taking, which of course the doctor needs to be allowed, the clinician needs to be allowed flexibility. Communication templates in the way we reach out to patients. Consent is a very standardized process that we have tested multiple times to make sure patients actually understand what it is we're consenting them for and what happens to their data, what happens to their information, what are they consenting for in that moment. And all of this is backed up by clinical and operational key performance indicators that we track on a weekly or monthly basis, as well as audit and review. So for example, every single consultation that we do is recorded. The recording is saved together with the electronic medical record, and we audit about 10% of the recordings every month to make sure that what is documented is actually what happened in the consultation, and there's not a discrepancy between those two. It's been very important to us to contribute to learning, data sharing, knowledge sharing as part of our commitment to quality in primary healthcare. So we are one of the few providers, telemedicine providers, that report all our data into the Kenyan health system, a KHIS. We obtained a license to offer continuous professional development so that the learnings that we have, including the mistakes, are things that we share through webinars ourselves. And we have monthly professional development webinars that are open to all providers in Kenya that talk about our experiences delivering different elements of primary healthcare, what we've learned that works, what we've learned that doesn't. Because, you know, we don't believe that telemedicine is exclusive to us. It is a integral part, I think, of strengthening the primary healthcare system going forward. And that has to be more than one provider. We have been very lucky and fortunate to participate as a sort of private sector exemplar on the Kenya Ministry of Health technical working groups around the Digital Health Act and the telemedicine standards. We are working with organizations like SafeCare to look at quality of care accreditation for primary healthcare telemedicine specifically. That doesn't really exist anywhere. There aren't really accreditation standards or any way easily for consumers to evaluate, you know, all these different providers that say they're doing the same thing. Where do I get quality? So we're working actively to try and support that. And, you know, participating in events like this and conferences, sharing, again, the data, the learnings that we have. At the core of all of our quality work is that we have built and continue to strive to build to the needs of our customers. For example, the need for 24/7 access. Many of our customers live in communities where they work a daily wage. And so it's very challenging for them to take the day off or even half a day off to go to a provider. Here, they can call us at 5 o'clock before they go to work. They can call us at midnight, anytime, day or night. And we really believe that is very central to a patient-centered quality primary healthcare service. We've built in mechanisms around language accessibilities. We have doctors and other providers that speak multiple Kenyan languages, including Kenya Sign Language, because for telemedicine and primary healthcare, you know, a community that we deeply want to serve are patients living with disabilities who are challenged when they enter and access a lot of hospitals and physical health infrastructure. Multiple channels to reach us, affordability and subscription based. So our service, you pay once, either for a month, a quarter or a year, and you get unlimited access to all the providers. And we feel this has really been powerful for us in terms of delivering preventive and promotive care, because typically patients will not call or pay for a consultation around a preventive care question. Whereas if they have a subscription, they may have called for a cough or stomach ache or something else, but now they have a month or a quarter or a whole year where they can call us back as often as they want to ask other questions. We see a lot more engagement in the preventive care, thinking and promotive care thinking, and it allows us as clinicians to do a lot more in terms of delivering what we truly believe to be quality. So this is just a brief introduction to some of the systems and structures that we've put in place as a provider, taking the learnings from the national level and implementing them internally. Thank you.
Thank you so much, Dr. Radha. There's a lot of interest in the platform, so please do answer the questions in the chat. Really just so interesting about how people access it through the hotline and the emphasis on preventative care through the system that you've developed. So congratulations. Let's move to our final speaker, Dr. Mayank Sharma, who is a Health System Strengthening Senior Program Officer at PATH in India. Dr. Sharma has more than a decade of experience of working on health system strengthening with government and non-government organizations in South Asia. At PATH, he supports the integration of vertical disease programs like tuberculosis, non-communicable diseases, and sickle cell disease into primary healthcare. And he's currently the lead of the District Primary Healthcare Model Pilot in Satara, India, which focuses on integration and improving the quality of care. So over to you, Dr. Mayank. Thank you.
Thanks, Ken. Always wonderful to be part of a panel with you. So hello to my fellow panelists and the participants who have made time to attend this important webinar. And before I begin expressing gratitude to the wonderful team at IPHC, JHU, and PATH, and thank you for inviting me for this webinar and sharing my India's experiences on this important topic. So over the next few minutes, I will attempt to share a glimpse of India's public health care system, how quality of services reflect in the health care priorities, the platforms for quality assurance in both the public as well as the private sector. A little bit of in-depth detail about the standards being adopted in the public healthcare facilities, and if time permits, I would present the work we are doing at PATH to support some of this endeavors and aspects of quality beyond the standards as well. So quickly, in terms of the whole public healthcare system of India, it's basically a fragmented system where 70% of the care is, catered to by the private sector. Majority of this care, more so for outpatient care, is paid for by out-of-pocket expenditure. The share of out-of-pocket expenditure as a percentage of total health expenditure remains high. It has the surveys show it has decreased over the last few in the last few years, but still a financial catastrophe due to healthcare costs remains higher. In terms of the structure, India has a three-tiered structure. The presence of urban primary health care was limited in the past decade, but there have been huge investments, especially during the time of COVID. So many urban primary healthcare centers are also coming up. There are high footfalls in the government-run secondary and tertiary care facilities, but however, these still have significant proportions of people availing primary care services. Some of the studies around quality of care showed high mortality due to poor quality of care and people having to bypass public facilities due to perceived quality of care issues. Just reiterating what my previous speakers had mentioned, and quality of care as per WHO is the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with the evidence-based professional standards. Efficiency, safety, people-centeredness, integration, equity, timeliness, and effective. These are all some of those traits. Moving on to what the priorities. So the latest adoption of national health policy happened in 2017, and the goal of attaining the highest possible levels of healthcare and well-being for all ages. Here you'll find that universal access to good quality healthcare services has been reflected. And in fact, public hospitals and facilities would undergo periodic measurements and certifications of level of quality has been clearly mentioned in the national health policy for the country. In terms of some major reforms that have happened in the last few years, if you see, in 2018, the government of India announced Ayushman Bharat. It has two major pillars. One is a government-sponsored health insurance scheme for the secondary and tertiary hospitalization. It covers 40% of the population of the country, and 5 lakh INR, that will be close to 6,000 USD is the package for that government-sponsored health insurance schemes. And the main one being, which I will be talking about in today's presentation, is around primary healthcare reforms. So there are the Ayushman Arogya Mandirs, which this reform on primary healthcare is called. Close to 160,000 of these primary care level facilities have been transformed. And when I say transformed, that would mean they have essentially the government wants these facilities to provide care beyond the traditional MNCH immunization and some form of vector control practices that used to happen. So there's a whole 12 package of services in these Ayushman Bharat. There would be a mid-level healthcare provider termed as community health officer, like a nurse trained in primary healthcare, which will be manning these facilities, and increased investment, as I mentioned before, on urban primary healthcare. The whole concept of integration of vertical programs at the level of these facilities, and in terms of community engagement, creating health community engagement platforms where community members like the local political representative, local elected representative, a teacher, and other community members are present along with the healthcare functionaries of the nearby PHC facility. In terms of the accreditation, now and just want to mention the insurance scheme also has adopted those quality standards that I'll be talking to now. So government incentivizes hospitals in terms of higher package rates for hospitals who have been accredited with these facilities. In terms of private sector, we have NABH and JCI, which are the primarily accreditation standards and organizations. NABH has also, beyond private facilities, some of the Indian system of medicines, or the traditional system of medicine facilities have also, adopted these standards. But, beyond this, moving to public health facility, and JCI is mainly preferred by corporate hospitals which engage in medical tourism. But coming to the public health facilities, the Ministry of Health and Family Welfare has defined the benchmarks for different levels of healthcare facilities. The latest revision happened in 2022. These standards, as you can see, National Quality Assurance Standards, the Indian Public Health Standards, they relate to services, physical infrastructure, human resources, medicines, and equipments. Coming to the National Quality Assurance Standards, there has been considerable evolution of these systems before the current mechanism was adopted. I could, read some of those evolution. I could see these evolutions happening when the previous speakers were talking about the experiences from different regions of Africa. And discussing this in detail in the next slide, this current system was launched in 2013 by the Ministry of Health and Family Welfare. These are based on specific needs of public health facilities and global best practices. They're accredited with the International Society for Quality in Healthcare. And these standards are broadly arranged under 8 areas of concern: service provision, patient rights, input support services, clinical care, infection control, quality management, and outcomes. So these meet these global benchmarking in terms of comprehensiveness, objectivity, evidence, and rigor of development. There are other standards for specific purposes like, labor room, child health, maternal health, and newborn care. So just to give a glimpse of, there are 4 levels of assessment: facility, district, national, and state. And these a certificate that a facility receives, in addition to some monetary incentives, is the outcome for these periodic monitoring and evaluation. Close to 5,000 odd facilities have been accredited so far. There has been welcome build-up in capacities for audit and certification. However, it would need much more scaling up to meet the requirement. The target for government of India is 50% of the public health facilities having gained this accreditation by 2025, and all 100% of the facilities by 2026. These are ambitious goals, and the capacity would need to be increased. There is also a need to establish state and district level quality circles for professional oversight. Something similar to what Dr. Radha was mentioning in her presentation. Some of the behavioral assessment, and I'll be talking about these behavioral barriers in the subsequent slides, but particularly around quality that we did in one of our projects, showed quality seen more from the lens of quality certification for facilities, making the idea very transactional in nature, and the notion of quality from the provider side as being too abstract. And so the healthcare facility staff will associate hygiene and job completion to quality. Data quality understood as timely filling up of portals and not particularly accurate filling up of portals. In terms of what PATH has been doing, in the past few years in India supporting, so we have primary healthcare projects in 5 states, particularly centering around urban primary healthcare and the district model in Satara. The support includes developing a behavioral understanding for quality from the provider side, capacity building of healthcare workers on quality assurance initiatives, as well as the aid in formation of quality circles. Quality circles is kind of, peer support groups for different level of healthcare functionaries to come together and discuss the quality issues, particularly around these standards and how to address these. Just to give a glimpse, there are 21 such checklist for a district level hospital under the National Quality Assurance Standards. Developing a lot of resource packages, helping support the district teams in conducting assessments for health facilities, internal assessment, gap assessment, and action planning. Some of these material I will share on the chat is freely available for those who would want to see. The standards are itself available in the public domain. So please feel free to use that. Now coming to aspects of quality beyond the standards and certifications. So inherently, we have tried to, at PATH, build a human-centered design approach to address these key behavioral barriers for uptake of primary healthcare services, both in the urban and primary healthcare geographies that we work on. Operationalizing these community health platforms, as I mentioned before, Jan Arogya Samitis, how facilitating the engagement, and it has given us some good results in terms of priorities from these community health platforms coming in the forum. For example, last we had requests around snake bite, and then we got together with the government machinery and tried to address that issue, which is usually not reflected in the reporting databases. Communitization of chronic conditions in terms of primary healthcare teams facilitated peer support groups for diabetes, hypertension, and sickle cell diseases. This essentially promotes medical adherence as well as self-care among people living with these conditions, and then rolling out models for decentralizing and integrating healthcare services. I hope I was able to just give that quick glimpse of what has been happening in India. There's much more that has been happening, and I couldn't cover all of these, but that was it. Thank you. Thanks, Kim.
Thank you so much. Thank you for 4 brilliant, interesting presentations on different ways of approaching quality and systematic ways in the public sector, private sector, and at different levels. I recognize that we have around 7 minutes. However, there are so many interesting questions that were asked in the chat. And I think the first question that came in was really about how do we embed a learning environment into the work that we're doing to try to improve quality, and are there ways to embed research, but as well as more routine ways of learning to address quality. So it'd be wonderful to hear from the panelists if there's specific examples, ideas that you'd like to share. Mayank, one of those things that you spoke to were the quality circles. That seems like a really important mechanism for learning and adapting, really trying to improve the quality of care. Looks like we lost Dr. Mayank. Okay, so as we are thinking about everything that we've learned across the 4 speakers, it'd be wonderful to have one takeaway message from each of the panelists, one message on quality that you think is really the most important to consider. So I'd like to start with you, Dr. Al-Hassan.
All right, thank you very much. And I was able to respond to some of the questions from the participants. Very good questions. I want to say here that my country, for example, Sierra Leone, is highly donor dependent. And what we have seen as initiative to address quality, I refer to them as projectified. Is when you have a donor, World Bank will say, okay, we need this for the next 2-3 years, we are going to give you money. FCD will come and say, let's do this for the next 2-3 years. When that program ceases to operate, then that initiative collapses entirely. So there is no sustainability wherein the government cannot take over. So we have this projectified health system based on what we get from partners. That is not helpful. Something will work out today, and tomorrow is no longer there because there is no more funding. To me, we know what works, but what do we do to make what works to actually work? So if we say we need input, a critical lever for primary healthcare, then where are the resources financially? The government must be willing to really invest in health. But this is not happening. Rather, we depend largely on our partners. And these projects are not sustainable. They are here for 3 years, max, then they go. So what will happen? No continuity. So that's the message for countries in the region that, hey, make health a priority, invest in health. That will make a great difference on how far we can go as nations in terms of health, nation, and prosperity. Thank you very much.
Thank you. That's a very powerful message. Invest in health. Over to you, Dr. Binyam, for thoughts about how we can strengthen quality.
Yes, thank you, Kim. So I think quality has been a small-scale investment in many countries, and the role the government is playing is so minimal. So I think making sure the government is leading the quality improvement, quality management effort is critical. And if the government is in the driving seat, having a resource which will be based on the quality adjusted indicators, quality aware leadership, quality related performance evaluations will be easy. So I think one of the questions which was raised by one of the participants is about sustainability, financing, and the likes. I think many of the things really falls as long as the fact that if the government is leading it, it may be somehow easy to influence the budgeting structure, the line items, and also influencing the performance-based financing, because performance-based financing in many of the instances are really based on coverage. Like in some countries, it includes quality. In some countries, it also adds value, efficiency, and the likes. But those things can be really managed as long as the government is leading it. So I think my message is let's make sure the government is leading quality.
Thank you. So leadership is instrumental. Without the leadership, it's very difficult then to scale and sustain quality efforts. Over to you, Dr. Karnat.
Thank you. My takeaway, I think my key message out of all of this is, quality in primary healthcare is something we all have to do together. This is not a public sector thing or a private sector thing. It's going to require all of us. And I think going back to what Dr. Khan presented at the beginning, this idea, that access and quality have to go hand in hand. They can't be separated. There's no point having extremely accessible facilities, either private or public, that don't truly deliver patient-centered and quality care. Equally, there's no point having amazing quality facilities that don't actually serve anybody. And so we've got to think about these things, I think jointly, the working together across the sectors, from little facilities like us to the national government. And I think for me, the one thing that I've learned in this journey is that quality doesn't have to be, it's not an abstract term, nor is it a scary idea. I hope what I was able to present today is that there are real little practical steps that all of us can take to make primary healthcare service delivery slightly better quality than it was yesterday. There are really practical things that can be put in place. I think sometimes we look at quality frameworks and measurement frameworks and panic that it's it's outside of our realm of control. And for me, these 3 years at HealthX have been really a learning on, we can start doing something about quality of care today by putting in structures and systems that work. Thanks.
Thank you, Dr. Karnat. So partnerships and really just being very concrete and practical, you can make huge difference in quality. Over to you, Dr. Sharma, for your final thoughts on quality of primary healthcare.
Thanks, Kim. I think what so far has worked has been, sorry about the internet issue, so it's going on and off. And I'm in office. So it's been much around the political will. So ever since the reforms worked, moving away from just having a physical infrastructure or producing more doctors, how do people, enable? And some of these political wills are reflecting not just in adoption of standards, but also having targets. While that also has the drawback of people moving just for achieving those targets, but that pushes essentially a lot of these facilities to actually achieve those goals. And if you see, in the next 2 years, all the public health facilities have to get themselves accredited. That's the political will showing. So I think that is the key. All the other components try to fit in if we have the political will. Thanks.
Wonderful. Thank you so much. So it really sounds like it's the financing, it's the leadership, it's the partnerships, and it's the accountability that are all essential ingredients to ensure there's quality of primary healthcare, and that we then see the strong utilization and uptake of primary healthcare towards our universal health coverage goals. So with that, I want to thank our stellar panelists for very deep, very rich, very thoughtful presentations, and for answering all of the many excellent questions that came from the respondents. I also want to thank IPCHEE, Johns Hopkins University, and also, of course, PATH for co-sponsoring this dynamic session. So thank you so much to all of you. Thank you. And presentations will be shared in the next few days.
Thank you very much.
Thank you so much, Dr. Kim, for an excellent moderation, and the presenters for sharing your experiences. So, and thank you for the participants for your active engagement and participating the session. So we'll be sharing the resources. So follow us. There will be a upcoming session on June 6th on non-communicable disease and community health workers. So the promotion will be sent out soon. So there will be a lot to learn from each other. So please stay tuned. Have a good day, good evening, good afternoon.